Am I audible? Am I audible? Yeah, am I audible, Dr. Ninad? Yeah. A very good evening to everyone. Good evening, sir. Dr. Balakrishna, sir. Am I audible, sir? Sir is unable to unmute. Yeah, we are changing some settings, sir, so that you can be able to unmute yourself.
Yeah, I think it's done.
Yes, sir. Very good evening to everyone. Good evening, sir. Sir, here from JIPMER.
Sure. Good evening. Thank you.
Yes, sir. Thanks a lot for accepting our invitation, sir, and gracing this occasion and accepting for our request for your presentation on target volume delineation, sir, in lung cancer. To tell about sir, sir has completed DMRT and post-graduation in radiation oncology, and he has been a respectable fellow in the Switzerland and John Hopkins University, USA. And sir is also a reputed visiting scholar in the Department of Radiation Oncology, University of Washington in USA. And currently, sir is holding the respectable post as Professor CMC Vellore. Inviting you, sir, to start the presentation. Can we have the screen share, sir?
Are you able to see?
Yes, sir. The screen is
Sure.
visible. Yeah.
Sure. Yeah. So. Shall I start or wait for one more minute?
We can start, sir. We can.
Sure.
Yes, sir.
So, very good evening to you all. And thank you for Jibma for organizing such a teaching session, and also to invite me to talk about lung cancer management with radiotherapy. So when Pooja asked me to talk about this, she has asked me to focus on motion management, and I would be doing that mostly. And to tell about myself and my background in lung cancer, I've been in radiation oncology since 2004. And my gating experience, it started with training under Varian in Clatterbridge in 2010. I've been treating IGRT and SBRT for lung cancers. We have a Clinac IX and a TrueBeam STX and a Varian RPM gating system and a 4D CT scanner from Siemens. So that's our technology we use. We are also expanding, and we are acquiring a Tomo as well as one with another simulator. So our lung cancer treatment numbers is bound to increase. As mentioned above, I've been in University of Washington earlier. So I was working with proton and photon therapy in lung cancer, as well as my research over there was on dose escalation in lung cancer, especially non-small cell lung cancer. We were trying to go beyond 74 gray in a biologically targeted manner. So I have some experience in image utilization in lung cancer and also functional adaptation. My current research interest in terms of lung cancer, been working on some perfusion sparing in lung cancer. We have a radiomics lab, AI lab in radiation oncology. So we are trying to generate a prediction model for pneumonitis using CBCT scanners. I have experience combine that also in our research. So that's basically about me and why about lung cancer to you. So I don't think you would need my video, and for better bandwidth, I will switch off that. Sorry. Okay, so in the next 40 minutes, I would be talking to you in the context of early, locally advanced, post-operative radiotherapy in lung cancer and oligometastatic setting. And especially I've been asked to talk about target volume delineation and motion management. Since Dr. Kannan has done a good session on target volume delineation in the same forum last year, I'm not going to detail on that. I will just top it up with a summary, and I will focus mainly on motion management. So at the end of this session, I believe the trainees would have an understanding of basic respiratory motion in radiotherapy, the various strategies that we already have, and understanding the 4D radiotherapy gating methods, and an idea about the technology that we have now and probably some in future. If we look at the role of radiotherapy in lung cancer treatment has evolved in maybe in the last decade with introduction of stage 1 non-small cell lung cancer radiotherapy as a new indication, and we've been getting several referrals, and the older indications like post-op for R1, R2 resections, as well as mediastinal upstaging when it becomes a pathologic. So the conventional indication, which is stage 3B lung cancer, where we employ chemoradiotherapy either as a sequential method or a concurrent chemoradiotherapy approach. And the latest referrals that we are getting is mostly in the setting where earlier we used to employ palliative radiotherapy. Currently, we are being asked to give a radical intent radiation with an intent to extend the progression-free survival. So that has become a new indication, and that has also opened up various possibilities for us in combination with targeted therapy or immunotherapy. So a paper that you can actually read upon what is the importance of oligometastatic disease in the context of a radiation oncology practice is from Yolanda Levens, and it's published in 2020, which is a very good paper to read. If I brief about the dose and fractionation employed in lung cancer, SBRT, as you all know, we have to deliver a dose of biologically effective dose of 100 gray or beyond, and should be less than 5 fractions to call it an SBRT. Chemoradiotherapy, a conventional dose is 60 gray in 30 fractions, which is standard, and various dose escalation strategies have been employed, but Nothing has been found to be fruitful, but even now several trials are running as to find out whether we can achieve better control with larger doses. Post-operative radiotherapy can range from 54 to 60 gray, and in oligoprogressive or oligometastatic disease, we can ranging from 45 to 60 gray in various fractionation schedules. And some of these settings we can also tactic body radiotherapy, that is less than 5 fraction, large single fraction treatments. When we deliver radiotherapy to lung, mainly the lungs by itself, because we are worried about pneumonitis and post fibrosis. We should have an idea as to the amount of lung that we can compromise in that particular patient to see how much we can deliver to the target without issues. Also, conventional dose restrictions are there for heart, spinal cord, and esophagus. They do not give us major problems in delivering radiotherapy with current available technology. Baseline evaluation that we follow in CMC, essential evaluation is spirometry and echo. With compromised lung function, we would do further lung volume study as well as 6-minute walk test. I've done a few lung perfusion mapping for some patients just to understand how the perfusion changes pre and post radiation and whether we could functionally adapt radiotherapy. And that is probably not the scope of this talk today. Coming to imaging and segmentation, when we talk about tumor volume delineation, the first and foremost thing that comes to mind is what imaging technology that we would employ. There is no ambiguity on this. PET is an essential component for lung cancer tumor volume delineation currently. Sorry. So maybe a decade back, we found PET scan to be a little expensive and we used to do without it, but now it has become more or less available in almost all centers. And it is essential, and a PET scan closer to the time of tumor delineation is very essential. How does PET influence the target delineation? I will come to it, but it generally reduces the target primary and increases the nodal target volumes. What is the basic scan on which you would be planning and contouring? That would be a helical CT, which would be done on your simulator. This by standard should be from the cricoid to the mid abdomen, and essentially 3 millimeter slices. Functional status yet to scans yet to be adapted to the workflow, so we don't employ them in radiotherapy planning. And 4D CT is now considered preferable if you have the technology. I would be talking about it. Briefly about the target volumes as such, as well as the nodal. I would again say you should go back to condensed press. Look into the details of how to draw these structures, how to identify these structures, how to identify the CT anatomy of this while you contour. And the consensus group has actually set the lung window for delineation to standardize this volume delineation. So that also is available and it can be employed. So primary has to be the post-chemo gross demonstrable extent of the tumor and not the pre-chemo volume. This is different in lung cancer because the give induction chemo to spare the lung from toxicity. So if the tumor regresses and lung have advantages, and we should be able to target only the remaining tumor. Nodal stations, more and more nodal stations may be picked up with PET scan. So nodal target volumes increase with use of PET. The question of whether to include the nodes which have disappeared post chemo, that has also been set in by the consensus group, that all nodes which were positive prior to chemo. So now, once you have delineated the gross tumor volume, the next step is the target volume, which is essentially the potential areas of microscopic spread of the disease. And in lung cancer, it is defined as a 5 to 8 millimeter microscopic isotropic gross tumor. And this can vary. Why is it 5 to 8 millimeter? It can vary. That is, it can be 5 millimeter for small cell lung cancer to as high as 8 millimeter for adenocarcinoma. For nodal stations, there are two approaches available. One is a 5 millimeter geometric extension to involved nodes, which is commonly employed. Another option is to include the nodal station as such for the involved nodal regions. So the entire involved nodal region can be included. This can lead to greater esophageal toxicity, but if you look at most of the trials in lung cancer, especially the dose escalation trial, which has proven that 60 gray is the standard, they have used nodal station delineation. Post-op setting, when you're doing post-op radiotherapy in lung cancer, we are supposed to include the pathologically positive nodal stations. So that is also very clear in terms of CTV delineation. When it comes to PTV, PTV corrects for the setup error, that is interfractional errors. Though we employ image-guided radiotherapy in lung cancer, our practice is to give a generous 5 millimeter PTV margin for all thoracic sites. And we have found that to be useful based on the evaluation of the errors that we see in our patients also. So PTV margin can be different in other centers, but we employ 5 millimeter. And then comes motion management. Motion management is basically to the concept of internal target volume. So this is the ICRU62 definition. So internal target volume is basically a margin that is added to compensate for the internal physiological motion. So in terms of, it is basically the respiratory motion. So to understand the dynamics of its influence on structures, this is a very good table published, which shows that the lungs move actually 1 centimeter to 3 centimeter in the craniocaudal direction, while it is a little lesser in the anterior directions. More than that, if you look at the diaphragm movements are much meter to 4 centimeter, and the chest wall movements can be 2 millimeter to 1.5 centimeter. So understanding these dynamics is important to correct for respiratory motion of the tumor. Also, this respiratory cycle, we have a short inspiration followed by a slightly longer expiration, and then following that for a less than a second. So this is for a normal individual, normal physiology. But when we speak about lung cancer, we are talking about a diseased lung. And mostly these patients would have been smokers, and it may not be the same. And hence I have included actually a picture from one of our respiratory mapping, where you can see the respiratory cycles here. Not all of them are similar. There is some irregular breathing, but some of them really match the picture that you see on the left side. So you may not find a pristine respiratory cycle in all the patients when you map it. So what happens when, so these respiratory cycles are quite periodic, and when you find that this is the amount of movement that happens to these structures, what is with radiotherapy? Obviously, it would affect, it helps, it leads to a drop in accuracy, which or a geographic miss or an increase in OAR dose. And this kind of error is called the intrafractional error. And this is more or less important if your treatment time is more than 10 minutes. It is very logical to consider that every respiratory cycle, you have a small error. It just adds up on a linear scale as the time increases. And it is significant, considered significant if your beam on time is more than 10 minutes. And when we have precision radiotherapy, which has been developed over the last 15 years, where we sculpt tumor doses to the shape of the tumor with a 2 to 3 millimeter accuracy. And when we are speaking about 1 to 1.5 centimeter movement in chest wall and diaphragm, this really affects the precision, and it goes against the concept of precision treatment delivery. So it is very important now to correct for this motion. And that is what we would be speaking about. So to correct for this motion, we also should understand what are the factors that would affect this motion. It's not only the regular physiological movements, but there are some variations in these movements. First and foremost, I told you the beam on time. So if the beam on time is very short, the error that is, the cumulative error that is added up is not significant enough for you to employ a correction. But if the tumor is in the lower lobe, that is close to the diaphragm, as you have seen, the movements in the diaphragm can go up to around 4 centimeters. This can be significant. Or a tumor closer to a chest wall, these errors can add up to a significant miss. This will be the same when we speak about very small tumors like T1 and T2 lung primaries, where the tumor can move out of the target volume if we are not employing correction methodology. Same with lung nodules or metastasis. What are the other factors that contribute to motion in lung tumors? Physiologically, women breathe differently compared to men. They are more thoracic breathers. The lower tidal volume, faster breathing rate, and physiological changes also happen in their different times of the month. So these all can affect a breathing pattern and can affect the targeting in women compared to men. What about immobilization? Does it have an effect on the breathing? We have two options, the aquaplast or the ray cast that we may call, and the vacuum bag. Generally, what we employ at our center is vacuum bag. It is quite easier for gelling it along with respiratory motion management techniques. There are papers which have actually compared vacuum bags versus thoracic ray cast and looked at whether the ray cast would really reduce the respiratory motion. And it has found that whether it be vacuum bag or aquaplast, the chest wall and the rest of the anatomy moves similarly, doesn't make a difference. The other philosophy behind employing various immobilization devices, I would speak about some of them, which are specifically catered to lung cancer motion management, is that first and foremost, patient has to be relaxed for employing, for correcting for motion. You would all know that. So as many gadgets that you use to immobilize the patient is bound to react to it. Even the intrafractional motion, apart from the physiological motion, can increase if you use too many gadgets. So to keep it simple, our philosophy has been to use just the vac clock and then correct for the setup error and correct for the motion using IGRT and motion correction methods. So that has been our philosophy at CMC. So now, what is motion management? So motion management is taking care of the physiological tumor motion within the single fraction of treatment by employing various strategies, technological advancements, while ensuring that we deliver the desired dose to the target and while keeping the dose to the organ at risk as planned. So when do you employ motion management? Not in all scenarios, as I said above, if the treatment time is longer, or in other words, especially in situations like SBRT or hypofractionated treatment, it is very important. And also that is often said is if the tumor excursion is more than 5 millimeter, it is better to employ this. And when normal tissue sparing is considered very important. And when not to do it is also important, where the clinical goals are met even without motion management, like in palliative approaches, where you are not doing any dose beyond 30 gray or 40 gray. When you have a non-compliant patient, when all these technologies fail, if the patient does the protocols, and also non-availability of technology, it's very difficult to ensure motion correction. Though technology has become simple, but it still entails purchase of newer equipment to correct for motion management. So this has been nicely put up in a workflow by the AAPM task group. You can read this document, the report 91, which is freely available in the internet. This is what I have spoken of in the previous slide. So what are the strategies that we have? Now that we have understood the physiology of respiration, we have spoken about the motion of the chest wall during respiration or motion of the tumor during respiration. And we have understood the various factors that may affect. What are the strategies that we can employ to correct for it? So there are 5-pronged strategy, which is motion mitigation, motion encompassment, respiratory gating, breath hold, and tumor tracking. Some of these may overlap also. You can also mix and match many of these things, but I will try to explain each of them. So what is motion mitigation? That is trying to reduce the respiratory influence on tumor motion to less than 5 millimeter. As we earlier said, 5 millimeter can be considered a cutoff for use of motion management techniques. If you can reduce it below 5 millimeter by some methods, then that is easier. So shallower breathing, reduce the amplitude of breathing. That's one way to do it. And many immobilization devices are available for SBRT. Body fix, for example, from Electa. There is Q-Fix is there. Various companies have brought in. This is a Clarity principle of an abdominal compression, so which can be graded, and that abdominal compression would movement of the diaphragm, very useful in liver radio SBRTs. We have a body fix with us, but we don't employ it as I mentioned earlier, that we feel that keeping it simple is better for the busy workflow in the department, as well as for the patient to be less anxious. So this is a cross-sectional CT showing how the abdominal compression works, and it has been proven in various trials that there is almost a 1/3 reduction in the target volume size with employment of abdominal compression. So and that has also led to this that the ITV that you need to employ if we are doing an abdominal compression can be 4 millimeter. And if as you know, the standard ITV that we employ in a non-motion compensated treatment, that is a free breathing technique, is 1 centimeter craniocaudal and 5 millimeter around radially. The 4 millimeter can be isotropic, that is all around, if we employ an abdominal compression device. So that is the advantage of a motion mitigation method. The next one is a motion encompassment method. So what are the strategies that we employ under this? There are 2-pronged. That is one without respiratory management, which is very commonly employed in most of our setting, and which is what I just told you, that is to give an internal target volume margin. This margin is a population-based ITV margin, that is based on studies done on hundreds of people, and we have found a median or a value within which 95% of the patients will fall under. So this is not a personalized margin, and this is 1 centimeter craniocaudal and 0.5 centimeter radial. What we have found in our center is that arbitrarily giving this actually leads to unnecessary larger target volume than what is needed. So ideally, identifying the real tumor motion in that particular patient and personalizing it will actually help reduce the target volume. But this is the standard of care as of now. What about motion encompassing methods when you have technology to look for motion, that is with respiratory management? That brings us to the 4D radiotherapy process. So what is 4D radiotherapy process? According to AAPM, it is the explicit inclusion of temporal physiological changes in imaging, planning, and delivery of radiotherapy. So there are 3 steps. It has to have an imaging, it has to be there in planning, and it has to be in treatment delivery also. There are situations where we actually do this only with imaging alone. So that is also possible, but the 4D radiotherapy process, ideal process, should include the approach in all 3 settings. So what is 4D CT? You can see in this GIF image, it's a 4D cine. So 4D CT is actually a CT scan which records the CT scan generally has an X, Y, Z axis, which are the 3 dimensions. here we have the dimension of time, that is the time within which the physiological changes happen in a patient. So while you scan, so we take a slow CT scan to actually encompass the tumor motion. That is one way of respiratory motion encompassment. You get an averaged image. Other way is to employ a 4-dimensional CT scanner. In the next few slides, I will explain what is a 4-dimensional CT scanner. So a 4D CT comes with a respiratory monitoring equipment. So the respiratory monitoring equipment that we employ is a real-time position management system from Varian. Most of you have seen it. It comes with an infrared box, a small box, which is kept on the just below the xiphoid process of the patient, which is standardized. We keep it and then we actually mark it and tattoo it so that it can be reproducibly positioned for treatment delivery also. And there is a fixed camera in the treatment room as well as the imaging room, and the same position, which will detect the transducers through infrared. So while the patient is on the couch and with this transducer in the abdomen, the respiratory cycle will be mapped on the monitor. So this is how it would be mapped. I have shown real images earlier in one of the slides. And once that is mapped, the system also connects to the imager or the treatment machine. And it can actually send inputs to the imaging machine to say when to image and when the imaging beam has to be switched off. So on and off is triggered by the respiratory motion. So it is actually a respiratory controlled beam on, beam off. Same thing in the linear accelerator also. So how does this take a 4D CT? Okay, before that, I spoke about the RPM system. There are other vendors and other technology available. This was an earlier system from Siemens, Anzai belt. I am not sure whether many people are using it now. Another popular one is the active breathing coordinator from a slightly invasive method wherein patient breathes in and out through a mouthpiece. It's a closed loop and the volume of the breathing is monitored and the respiratory cycle is mapped same as the RPM system. So when we speak about respiratory mapping and the acquisition, this is how it happens. The bottom line shows the couch position, and the pink line is the respiratory cycles. So in the first couch position, the helical CT will be triggered to scan in various phases of the respiratory cycle. So in most 4D CT scanners, actually 10 CT slices. So this is a slower process. It will in the window that you set, maybe from the criteria, each couch position, 10 slices will be taken. So essentially at the end of a full pass, there will be 10 CT scanners acquired as compared to a single CT scanner that we have done in a regular helical CT in a planning CT. After that, there are two ways with which, so confuse this with that. Beginning, these slices are stacked phase of respiration and then made into 10 different CTs. So it's basic process of reconstructing the slices to become a full CT set. So it can be either done based on the amplitude, divided based on the amplitude or the phase. This is not very important for us, but phase binning generally is more accurate in finding out the irregularities in breathing. Whichever technology we employ, we actually get 10 sets of CT scans. So this is one phase binning example. So here we have the 0 phase scanner. All the 0 phase will be stacked together. All the 30% phase will be stacked together. Like that, we will have 10 sets of CT scans. And that is the 4D CT acquisition. Then comes the post-processing of a 4D CT. So here you can see the 4D CT cine. Sorry, this is actually, Okay, what you see in the right upper corner is a 4D CT cine, where you can actually employ that. In our variant Eclipse system, we can actually do a 4D cine play and then actually visualize the tumor motion based on these 10 CT scanners, CT scans that has been developed. Another method is to draw the GTV in all the 10 CTs separately and then fuse them and then see the motion or the track of motion of the tumor. That is one method that employ. But now technology is simple, software is there. The system by itself will reconstruct a post-process image called the maximum intensity projection. So in a maximum intensity projection, what happens is that if for a particular coordinate or a particular voxel, you have 10 sets of images because you have acquired 10 CT scans. For a voxel A, the of the 10 voxels that are available, the voxel with the maximum Hounsfield unit will be selected for reconstruction. So all the voxels will be selected based on the maximum intensity, and you reconstruct a CT scan. That CT scan is called the maximum intensity projection. Essentially, it gives you the entire track of motion of the tumor. What I suggested that we can do by drawing 10 different GTVs and fusing them, it can be done by developing this reconstruction CT set. The opposite of that is a minimum intensity projection, and an average Hounsfield unit image created is called the average intensity projection. So this is how it looks. This is also taken from AAPM. This is the regular helical CT. The regular helical CT is also a time average CT because it doesn't stop the breathing. So it depends on how fast your scanner is, that how much of respiratory averaging happens in the image. So that is what we generally a diagnostic radiologist will call it the artifact. But for us, if you take a slow CT scanner, it will actually give us the motion of the tumor. The second one is the maximum intensity projection, which as I told you, will give you a larger shadows because it takes the maximum intensity and then reconstructs the image. And this is the minimum intensity projection. So what is a maximum intensity projection is used for ITV delineation because it actually tracks the path of the tumor. You don't, you have a personalized internal target volume. The CT scan itself tracks the entire path of the tumor during respiratory cycles. So, the average intensity projection is generally used for a dose calculation process. So if you are employing maximum intensity projection for your dose calculation and 4D CT, the physicist uses the average intensity for a dose calculation for accurate dose calculation. So what is the advantage of GTV? So this image actually shows you, this is the real, the left upper corner picture is the real size of the tumor because this is not influenced by respiration, and this is the slice taken in one single phase of breathing. So you're stopping time here, while MIP is a composite of all the phases, which is much larger than this. What we generally get with helical CT is something in between, depending on the speed of your scanner. So advantages of the GTV MIP, which is what we call for this new recon CT, is that it gives you, as I said, it gives you the ITV for this patient, and it's a personalized ITV. And if we are employing this ITV for targeting the tumor for delivery of radiation, then we should use the same methods that we employed to track the tumor when we acquired the image. So if you are using a RPM device in the CT scanner and using MIP method, then you have to use the RPM device to deliver the treatment also in whatever type of monitoring that you have employed, which I will come to now. So just to show you the advantage of an MIP, this is from our scanner, one of our patients. This is the GTV on free breathing. The second one is a conventional ITV, that is a population-based ITV with 1 centimeter and 5 millimeter margins, and the PTV that is grown to that ITV. So this is how a conventional motion encompassed conventional method without respiratory technology employed. So what if we use the MIP method? This is again the same GTV. This is the GTV MIP. we can actually see that this particular tumor doesn't move much with respiration. And I can just directly give a PTV to that, and hence the target is much smaller compared to what it would have been if I have used the population-based method. So generally what we have seen is that if we employ the MIP-based respiratory techniques, our targets are becoming much lesser, hence more tolerable, more successful treatment outcomes. So it is generally useful. The next set is in the strategy for respiratory motion management is respiratory gating. This I will go a little more detail. As I told you before, gating, the essential step is that you need to have a respiratory motion management technology or a software which actually can trigger the beam on and beam off either in the CT scanner or in the simulator. So this is essential for gating. And a gate is when the signal for beam on is given. So the gate is set by the clinician based on various criteria. So switching on the beam on and off based on the respiratory pattern to accurately deliver radiation, correcting for tumor motion is gating. So what are the various strategies of gating that we can employ? I just spoke about the MIP method. When we use a 4D CT scanner to generate an MIP, we are actually using the entire respiratory cycle divided into 10 bins and using all the 10 CT scans to actually create a maximum intensity projection. Then my gate is the entire normal respiratory cycle, that is between the blue and the red. And during that normal respiratory breathing cycle, the beam patient will be treated. This kind of gating is called the free breathing gating or the backup gating or the gate 100. So why do we employ this? One is to ensure that we use the MIP technique, and MIP technique will work only if the patient breathes in the same pattern. So it's very important to monitor that. And when we monitor that, if the patient breathes out of phase or the patient coughs, it goes out of phase, the beam will be switched off. So that's the advantage. So it's basically a monitored, controlled radiotherapy where you have given a personalized ITV. That's essentially what a backup gating or a free breathing gating is. A little more advanced system is the phased gating, where we know that the most stable part of a respiratory cycle is the end expiratory part. So from 30% to 70%, if you select, that is the time when which the chest wall motion and the rest of the structures are moving the least. And the process is the same. You do the same 4D CT with 10 bins, but you select only the bins from 30 to 70 for your MIP generation. And when you treat, you give the gate as 30 to 70 so that the beam will switch on only when the patient's 30% to 70% respiratory cycle is there. So at every respiratory cycle, beam switches on and switches off. Problem with that is that it increases the delivery time. So this was the original idea for when the respiratory gating technology was brought in to do a phase gating, but many centers found that it is time consuming and adopting respiratory gating was difficult, though the targets tend to be smaller, because as you have seen in the previous image, I would say here, yeah, this is a phased scan. The target is accurate and small, and hence it is advantageous, but it tends to be very time consuming. So that is why to be more practical and to adopt to the workflow, a free breathing was suggested. It doesn't switch off and on if the patient is breathing in the regular breathing pattern in which the CT scan was acquired. So you can actually see in the RPM gating on top, it will tell us how much extra time that the patient would take if we were to employ that particular gate. So in this particular gate where we do a full gate, it's no additional time. That is what into one means. I can show you in other slides where it actually extra time that you would take to deliver if you choose a smaller gate. So there are two kinds of, as I said, there are two kinds of gating, which is phase gating and amplitude gating. Don't confuse it with phase binning and amplitude binning. The process is kind of similar. If we put the gate between in the x-axis, that is in the 30% to 70% of the respiratory cycle, that is called a phase gating. But if I say I can radiate when the patient breathes to 90% of his respiratory capacity, that is called amplitude gating. And amplitude gating is more possible if you use a technology like active breath coordinator with Electa, because that uses a spirometer to actually look at the volume of breathing. Here it actually shows you each kind of technique, how much extra time it takes. So if you are using a phase gating, for each respiratory cycle, if you are switching on and off, it actually takes 4 times the beam on time that is actually needed for a regular treatment. So the difference here in amplitude gating is only 3 times. These are the system itself will tell you, and you can choose accordingly. And the or an often employed and popular method is breath hold. This is sites other than lung primaries. So here, this is a real breath hold picture from one of our patients. His actual was around 1 to 1.5 centimeter, and he's a healthy man, so his deep inspiration goes up to meter, and we give the gate into which he is asked to hold the breath. So once he holds the breath, the green means the beam or the image is being acquired. So this method is deep inspiratory, that we need to map the respiratory cycle and should have the technology. Patient needs training to hold the breath in that level, and they also need a relatively not maximum inspiration. We generally find that this is employable if the patient can hold breath to be. This expands the lung volume. As the lung volume expands, you have more area to play with, less of lung top, reduces the lung doses and the normal tissue doses. So this again is where you have actually arrested the motion of the tumor. So the tumor will be well defined and not with fuzzy edges because of motion. A well-defined smaller target you will get if you are employing a DIBH. I generally use it for our SBRT treatments and find it to be useful for that, though other techniques can be employed, which we mentioned earlier. So the only error that you have to add here is the setup margin. This is mostly employed, as you know, in left-sided breast tumors, wherein the lung is healthy, patients can hold breath, and we have it has been proven that the cardiac probably it will reduce mortality also. So the pH is among the respiratory compensated techniques. This is something which happens very fast within 2-3 breathing cycles. Treatment and all, 2-3 breath holds, we can actually finish one fraction. Need a good patient training. A non-compliant patient, this is difficult. To improve training, we have actually developed a video output from the RPM device to the patient VR camera, so that the patient can actually breathe into the gate and then see how the curve goes, and then hold the line between the 2 gates. So that we have employed, and the new variant systems actually come with an inbuilt patient feedback camera. So and as a good lung function, if you are treating a non-small cell lung cancer stage 3B with chemo radiation, because I don't expect that patient to hold breath like the other patients. Another breath hold technique is the mid. This is the Electa's technology generally uses this. A deep inspiratory breath hold is found difficult for some patients. So, and it's found that 70% mid inspiratory is more comfortable. This can be employed if you are actually monitoring the breathing. Employs this technique. The final one, tumor tracking. I won't elaborate too much on. Have this technology, and I don't use this much. My experience with this is limited and as good as what you have read the journals. So tumor tracking is basically two methods. It can at fiducials because for the current available technology to target the tumor, it has to have something to track. It cannot just track the tumor using X-ray. It needs to have planted in the tumor. That is initially when we used to have tracking. Similar to that, it can be done for lung also, but percutaneous implanting of these has led to pneumothorax and it has become less popular. So people moved on to externally implanted surrogate fiducials. Currently, CyberKnife and Calypso technology employs it. I don't know whether the latter is still popular. Advancing on that technology, what it would lead to is real-time beam alignment, tracking the tumor, and then modifying your beam intensity based on the current tumor motion. How does it do that? This can happen in protons. This can happen in photons. It can either by moving the couch and bringing the patient to the right place. It can be either other ways to move the beam, which happens in CyberKnife. CyberKnife is actually a mix of tumor tracking, predictive motion, as well as using surrogate on the chest wall surface. And the Vero dynamic tracking system from Japan, which also has a method with which the dynamic MLCs actually move according to the predicted motion of the tumor. So these are advanced technology. I don't have experience with it, so I can't talk more on it. But I would see the future tracking methods wherein predictive motion method, that is after observing the tumor, computer would be able to actually predict where the tumor would be in the next second, and the MLCs would be anticipating that and moving things faster. Another question that may come is, what about the new technology like Align RT from Vision RT or the Identify system from Varian? As of now, they are not solutions for respiratory motion management. Even if people have employed it, it doesn't find us. Technically, it cannot have a standalone solution for a 4D respiratory motion management. So all patients will not be a candidate for respiratory motion management. I have detailed certain criteria to choose be based on the available equipment and the workflow in the department. Understanding the physiology of tumor motion, the kinetics of the respiratory motion, the technology that is available, and the uncertainties, not only the interfractional as well as intrafractional uncertainties which can affect the treatment, is important to direct the right patient for the right technology. And most importantly, we need to have a very coordinated team approach, and I find we need very smart radiographers. Otherwise, you would be spending most of the time in the machine treating one patient, which is not ideal in Indian scenario. So thank you. I think I tried to make it simple and cover as much as possible. I would be happy to take the feedback and questions.
Thank you very much, sir. Thanks, sir, for the wonderful class on the practical aspects, especially the target volume delineation and especially the motion management and the practical points so that we can take home and implement in our practice, sir. Sir, can we go ahead with the questions regarding the doubts, sir?
Sure. Shall I just read out the questions then?
Yeah, sir. Sure.
Yeah. So the question one is from yourself, I think. Is there any difference in target volume delineation in compared to radical RT? Recently we did a post-operative radiotherapy. Generally, I did not employ this because the target, as you know, in a post-operative radiotherapy is mostly the bronchial resection margin and the mediastinal nodes, where the motion effect is much lesser. As I said, 5 mm or more excursion is needed if we have to employ such technology to make it beneficial. So I did not use in post-operative radiotherapy, and that is in adjuvant RT setting. We can always do if you have a 4D scanner, we can always do a maximum intensity projection, and then take a call whether to employ it or not. If the MIP tumor volume is similar to the GTV, then you need not employ it at all.
Yes, sir. Thank you, sir.
While giving constraints, should we target to achieve the lung OAR dose? Should we target to achieve the lung OAR dose in the volume, lung minus GTV? Okay, so generally is in a average lung function patient, 1/3 of the lung can be compromised.
Okay, sir.
I would generally look at the lungs as a single structure to be less than 30%. If that satisfies, I would be happy. In a patient whom you cannot achieve this, then I would look at the lung, whether that satisfies this. But primarily, philosophically, I would go for the entire lung, which is lung minus GTV. That is the entire functional lung. Yeah.
Yes, sir. Thanks, sir.
Next, to consider what you want to say, I am happy to take that suggestion also. I mean, this anybody else want to answer also is fine. What do you do, Chandramouli, there?
I think we are following lung minus GTV only, sir, as you had advised, sir. Yeah. The remaining lung we are trying to save as much.
I think with the current VMAT technology that we have, we are able to get good plans with good lung sparing. It has been difficult earlier, but now I think the newer softwares are much better in giving us these constraints. Is it better to go for mid-ventilation CT approach or mid-position for motion management using 4D CT scanner? Mid-ventilation CT or mid-position for motion management? I don't understand the difference between these two, Chandramouli. Can you elaborate?
Regarding that, during 4D CT, sir, like it was given in some literature, like there are two approaches: mid-ventilation CT approach or mid-position CT approach. Mid-ventilation CT approach is like during the respiration cycle, in the mid-ventilation, the CT is taken, and in this mid-position approach, it is using deformable registration. So
I'm not sure of the latter. The mid ventilation is basically what we spoke about in the 30-70 gating approach.
Yes, sir.
Seems to be more stable. So that is a phased gating. But practically, all this cycle, it's going to be difficult to deliver in our setup because it takes long time to finish a treatment. So I generally use backup gating. That is, make the patient breathe regularly. Regular breathing cycle is monitored and give a full gate for the entire respiratory cycle. And I've made a MIP for that full motion. So that is how we manage, and that means the patient can finish treatment as a regular within the regular treatment time. No additional time is required. So that is what we do in our setup.
Okay, sir. Thank you, sir.
How much dose completion should we go for adaptive replanning with respect to lung cancer, sir? So I don't do adaptive replanning for lung cancer. If there is any issue with patient weight loss or something, then only we reactive step, not a planned step. So I don't do. Do you do a replanning for lung cancer?
No, sir. Here we are doing the same way only, sir. With the initial volume only we are proceeding, unless there is a weight loss as you had advised.
Yeah. So if there is a collapse, these concepts are there, but this has to be individualized. If there is a lung tumor which is resulted in a collapsed lung, then as the treatment proceeds and the lung expands, then the radiographer will be picking up PCT. At that point, we have done adaptive replanning. No. But this is very rare because we don't non-small cell lung cancer. And most of our patients, if they have a collapse upfront, we do it sequential radiation, so that if the lung had to expand, it would have done after chemotherapy. And And this also may be seen in small cell lung cancers, which also we seldom radiate, areas where I expect that an adaptive replanning can be done, where a lung re-expands after a few fractions of radiation. But that is a reactive adaptive planning, not a planned one. Has changed, then you plan. Should any atelectasis or pleural effusion be included as or delineation of OAR lungs? Okay, so atelectasis is definitely not, because that will damage your lung. You are expecting the tumor to regress and the expand. So if you are radiating that, that re-expanded lung is not going to contribute to the lung function in future. Pleural effusion, there are most scenarios where we exclude pleural effusion in the treatment is a post-op patient where we see local effusion, which is related to the surgery, and then we exclude that. But in a radical treatment, if we find pleural effusion, such patients we seldom radiate actually. So because we have to prove it to be we have to prove it by pathological methods to that it is not a malignant effusion. If it is a malignant effusion, then we don't radiate. So I don't know whether that scenario exists. Do you want to correct me, Chandramouli?
Thank you, sir. Actually, we are regarding that adjuvant cases having pleural effusion. Thanks for giving us that take-home point, sir. And this radical also, we are leaving it as such, sir. We are not including it in the OAR or the target volume. Okay. That's what we are practicing here, sir.
Okay, so this question number variable CTV margins for squamous cell carcinoma compared to adenocarcinoma. The limiter for squamous and 8 for adeno. I don't think we do a difference. We just go for the maximum in our situations. Yes. So in cases where neoadjuvant chemotherapy was given, should we go for post-chemo volume as GTV and pre-chemo volume as CTV? Sir? No, I don't think so, because it's very clear. See, we give chemotherapy. We give chemotherapy because the patient's initial target volume is an intolerable radiotherapy field. That's when we say give chemo, let the tumor reduce, and then let me give radiation or chemoradiation. So if I'm going to go back and radiate the original volume, then it is still intolerable. No?
Yes, sir.
So other issue is chemotherapy is given with the intent of reducing the target volume to expand in. And if the expanded normal lung is also being radiated, then that advantage is also gone. So it has to be the post-chemotherapy volume. And you have to employ a PET scan to target that. That is very important.
Thank you, sir.
Which would you recommend for motion management, DIBH versus 4DCT? Depends on the situation. I wouldn't use DIBH for a non-small cell lung cancer stage 3. But I have done DIBH for SBRT situations where I find that to be faster and smaller target volumes. So whatever SBRT we have done, the patient could hold the breath, we have employed DIBH. Whatever non-small cell lung chemoradiation we have done 4DCT with free breathing and backup gating.
Thank you, sir.
For selection of patients for DIBH, how much minimum duration should the patient be able to do breath hold, sir? I said no. This is from my personal experience and what our radiographers say, 20 seconds. The last patient, what we did breath hold had 2 targets, one in either lung. We did SBRT, 60 gray in 3 fractions to 1 tumor, and 40 gray single sitting to 1 tumor. So initially she was holding only 20 seconds and around 20 to 30 seconds. Around the 3rd fraction, her holding had come down. We had to give her steroids and all, and then delay the treatment. The last sitting, she was holding around 30 to 40 sitting. It was tough, but we tried to finish it. So minimum, what we say is 20 seconds, but ideally up to 40-50 seconds people do hold and we treat them, and that is more comfortable.
Sir, another thing, is there any age limit for this DIB? It's like beyond this age, we don't go for
or something. So I don't think we go for that. But older patients, if you see, patient selection is, if they can't hold breath, if their breathing cycles are irregular, then I don't think they are candidates for motion management. Instead, you actually give a population-based margin and make sure that 95% of the time they are within that.
Thank you, sir.
PET helpful in any way for port in lung cancer? I would do PET in port in lung cancer if the patient has been an upstaged N2, because the upstage N2 is a setting where the patient has been operated thinking that it is a N1 or an N0 disease, and the surgeon, when he sampled, found that it is N2. So there might be lymph nodes that has been missed. So possibility is there. So I would do a PET. Secondly, in a setting where it is an R2 resection, where I want to delineate the residual tumor, these are situations where I would do a PET scan. Recently, we did a PET CT for a patient who was R2 post-op with R2N1. So yeah, we did a PET for him. And as you rightly said, there was some local pleural effusion. There was some collapsed lung adjacent, which we were able to exclude by use of PET. That we generally do in post-op patients is to call the surgeon over and ask them to cross-check the drawn. So these 3 steps very important.
Thank you, sir.
Any other question? Okay, Sumit has asked whether I can explain the free breathing once more. Is it?
Yes, sir.
Is that right? Yeah.
Yes.
So let me go back to that slide. Okay, this one. So herein, what you see in the blue line is the upper limit of the gate, and the red line is the lower limit of the gate. So we have fixed the gate. I generally keep it 5 millimeter above the general respiratory high and low. This is the gate within which we are saying the beam can be on. So we are letting the patient breathe in a normal periodic pattern that they generally breathe. We are mapping that. We are keeping the gate within that. We image in that. We generate the maximum intensity projection, which is actually a composite of the tumor motion through this regular breathing cycle. We don't give a separate ITV. We just give a setup error margin to generate a PTV from that MIP. CTV definitely we will give. And once that is done, when the patient goes for treatment, the same gate is employed, same respiratory monitoring is employed. If the patient breathes out of phase, that is generally when they cough, or if they have some kind of respiratory issue, they hyperventilate, and it goes beyond this, the beam automatically stops. Within this window, we have already accounted for that error by generating the M. So this kind of gating is called the free breathing gating or the backup gating. Is that clear, or do you want some more?
Yes, sir. It's clear. It's clear.
Where was that question? Sorry. Okay. Minal has asked, in places where we don't have motion management, what's the value of having scan with free breathing, deep inspiration and deep expiration? So I'm rephrasing the question. Tell me if I'm right. If you have a 4D scanner, but you don't have a motion management system, is that what you're asking? Unusual to have that. Okay, just a CT scanner, and then in that situation, you can only employ the population-based ITV methods. Is somebody else doing anything else? They can also add into the answer. But I would tell you that, see, I've been trained in gating methods since 2010, but we bought our 4D scanner in 2017. I was away and I came back in 2019, and since then only I've been using this. So without that, before that also we had CT scanners, but we couldn't employ motion management techniques. the appropriate technology, it's difficult. Light on PET fusion for G. The available current software, it's quite easy. If you can have the PET in the treatment position, the fusion is easy. But current, for example, variant that we use, Eclipse that we use, even if you are not in a treatment position, the deformable registration will actually take care of that and then fuse it correctly. So the registration process now. For nodal volumes, GTV-N with margins as CTV, sir, or both, which is okay. I said both are possibilities, depends on your institutional preference. As I said, we follow the 5 millimeter margin because if you include the entire nodal station, it generally becomes esophageal toxicity. But if you look at the earlier trials that have employed dose escalation and all, they have actually both approaches are good. Can't find fault with both thinking, but one of them is less toxic. Okay, binning, as I pause that. Okay. So this is phase binning. Okay, so phase binning is what we generally employ, where you divide the respiratory cycle into 10 phases. Every couch position, the scanner has acquired 10 images, one for each. So you have, let's say, 100 couch positions in one pass. You have 100 into 10 slices now. So 1000 slices. Now, in a binning process, based on, so the zero phase, all the zero phase slices will be binned together to become one CT. Then the 10 phase will be binned together. Like that, all 10 phases will be sorted out. That sorting out and reconstructing the CT is called binning. This can be done in the amplitude direction also, which is called amplitude binning.
I think that's it for the question, sir. Thanks for
that's the end of the questions. Yeah.
Yes, sir.
Thank you.
Thanks for explaining us all our doubts, sir, and clearing the doubts patiently.
Sure.
Yeah. Thanks for the wonderful class, sir.
Thank you, Chandramouli, and thank you, Pooja, for calling me. Thanks. Thank you very much. Have a good night and Happy New Year to all of you.
Yeah. Thank you, sir. Happy New Year to everyone. I think we can end the session. Thanks.